We are live now, Doctor. You can start the session.
Good evening, friends. We have a momentous day this evening, having an exclusive program of ERCP with the masters in the country. Ladies and gentlemen, it is always a honor to get blessings from the father of endoscopy in India. Can I invite Professor Krishna Rao sir to bless us with few words before I hand over the proceedings to the event moderators? Dr. Krishna Rao sir, please.
Thank you, Kalikavel. It is a unique experience to have this web seminar on ERCP as a part of a book to be published by Ishwar Murthy on a later date. The object of this is to disseminate the problems that about the history and the procedures that we can do in this webinar. And I'm sure this will benefit not only the viewers who joined us, but also those who will be pursuing the textbook that is going to be released by Krishnamurti. I wish him all the very best in this endeavor.
Thank you, sir. Friends, we have very eminent speakers for the evening, but as a matter of fact, as a matter of protocol, I've been asked to briefly introduce the respective faculty. So let me have the honor of introducing one by one. Professor G.V. Rao is a very eminent surgeon by himself, and Asian Institute of Gastroenterology being effectively head by him along with Professor Nagi, is been making strides in basic sciences, translational research, artificial intelligence, and it is respected above all the premier institutes in the country for the coveted teaching program which is happening in the center. Then Professor Praveen Suryavanshi, again, is the Dean at the MGM Medical College, Aurangabad. He heads the HPB division and he is heading the fourth center where they have the accreditation for MCH HPB surgery. And he has one of the world-class endoscopy suites in his department. And much respected for his endoscopy related activities when he was the immediate past president, and the legacy continues. Warm welcome, Praveen sir. We have the honor of having Dr. Bhavnit Singh Balla, again a very eminent surgeon, and he himself is the academic head of the World Laparoscopy Hospital, Gurugram, and we are expecting Dr. Anmol to join. Friends, our leadership board is again having very eminent, the president, past president, everybody are surgeons by themselves and very busy endotherapists who believe in directly investing on the state of our technology. Dr. K. Govindraj, the president of the IAGS, has been master inventor for the technologies, and he invests on the best of the technologies, and he has the entire armamentarium of the endoscopic gadgets, accessories, and he has been instrumental in getting the IAGS, the state-of-art trainer, the artificial intelligence-based trainer Mikoto, for the benefit of the fellows who are getting fellowship graduates from EFAGS program and the FAGI Advanced program. I have the honor of welcoming Dr. Govindraj sir for this program. And the master mentor, a man who has trained more than 300 surgeons in endoscopy and advanced scopies. Today, in fact, I'm very, very proud to share. I've received news from Olympus that the adaptation rate for untrained endoscopists after getting our IAGS training is up of 74%. And people who have been working in a teaching center, the adaptation rate is even higher, 88%. This is the most updated data for the last month. So it's very heartening to see the training efforts are reaching the people, the trainees, surgeons themselves, and in turn, they are getting benefiting the society. So in this arduous task of training the surgeons, the endoscopy and the endotherapy, this is yet another golden day where people are trained for next generation, that is those who are completed endoscopy and yes, colonoscopy training should move on to the next more tougher arena, the ERCP. So today, Dr. Ishwar Murthy sir and Dr. Govindraj sir together are going to break down the tough aspects, make life easier, establish systems, and give you clear solutions. Ladies and gentlemen, I welcome the moderators for the evening, Dr. S. Ishwar Murthy sir and Dr. Govindraj sir. Welcome, sir. Please take over. Thank you very much for the opportunity to moderate.
Thank you, Kanavel, and under the guidance of Professor Krishna Rao, the father of endoscopy, our president Govindraj, I welcome all of you and all my panelists who are going to be with us to give, because all of us are now trained in endoscopy, colonoscopy. Now we want to move to the next stage of ERCP. To be a proficient in ERCP, there are a lot of things required. We need to learn the technique. We need to develop a team. We need to know the nitty-gritty of all the tools, and we need to have the right temperament. So all these things won't come in a single day. It needs a lot of input, and just reading the guidelines or seeing some videos may not be enough. We need to have a thought process. We need to have a mentor. So we have right now four of our mentors along with our professors and our president himself. So we are going to brainstorm and come out with how we can make ERCP a very simple technique for us to learn. So we are actually coming with the guidelines for a manual called ERCP Simplified, ERCP training for the surgeon by the surgeon. For that note, let me ask them all 30 frequently asked questions in my opinion. And they are going to be very brief in their own mind. What for each question could be the ideal answer, and we'll take it from there. To start the ball rolling, I would request our Professor Krishna Rao himself, please unmute, sir. See, you've been there. The 60 years is a long years in the history of ERCP. And there are a lot of personalities, both national and international, starting in a name few like Professor Nagireddy, Amit, and all our faculties here. But there are some figures which might have fascinated you with the path-breaking innovations. Can you name any of them which still linger in your mind, sir?
I think the first ERCP is attributed to the Japanese surgeon Itaro Ui, who in 1960 had the concept and had cannulated the biliary tree. But when we go through the history, William McCune, an obstetrician, is credited with doing a sideways endoscopy and ERCP and delineating both the biliary and the pancreatic ducts. Next in line will be the Klassen, Meinhard Klassen, and Kiichi Kawai from Germany and Japan for having done the sphincterotomy and entered the biliary tree to remove the stones. But the name ERCP was coined by Peter Cotton around 1972, and that has stuck as the thing for the endoscopic retrograde cholangiopancreatiogram. Next comes uh, the, the Indonesian who has become a German, Nip Sohendra, who has put in a number of homemade accessories at a time when things were very expensive. It is from him that I learned how to prepare multiple stents of different sizes to be inserted into the biliary tree for drainage purposes. And after that, in India, without any doubt, the first ERCP and stenting was done by me and recorded in the ISG journal. Thereafter, Dr. Reddy, Dr. Amit Medo, and others have followed suit and have done excellent work in this country. It's too numerous now to enumerate them according to their seniority, and I will leave it to you to gather the information and put it up in the book.
Thank you, sir. Thank you. What started as a diagnostic curiosity, now it is going to be a therapeutic reality. And a lot of developments have happened. Thank you to hear from you the developments as you watched them all personally. And let's ask Dr. Govindraj to take over.
Good evening, everyone. I'm so honored to have all the elites of therapeutic endoscopy in this panel. And that too, I'm so honored to have Professor G.V. Rao. Professor Rao, I would like to know, because as a surgeon, we all are so fascinated about the anatomy in which we operate. And particularly when you do an ERCP, how does the anatomy of the ampulla of Vater or the sphincter of body, how it is so important as an ERCP, as an endoscopist, the 3D anatomy, how is it so important? How do you think this can really be very helpful to learn the art of ERCP, otherwise to the tips and tricks, how this anatomy has helped you so far?
Gondraj, is it okay that I can share my slides actually?
Definitely, sir. Yes.
I'm just sending a request. Can you just allow the request?
Yes, sir. Sai, can you allow Professor to share the slide?
Done, doctor.
Yes.
Hope you can see this.
Yeah, you could see some.
Yeah. Basically, can I have about 5-7 minutes?
Please go ahead.
Maybe, sir, we are not able to see that full thing. We are seeing your display of the folder.
Oh, sorry, 1 second.
Probably please unshare this and share the desktop screens.
Is it okay now?
Not, sir.
It's
Still,
coming.
Still,
It's coming.
It's
No,
coming
it is
now.
just.
It's starting to share.
Look. Yeah.
Yes,
sir.
we got it, sir.
So basically, the word ampulla comes from an ancient Roman glass or an earthenware flask with 2 handles actually and a globular body made to hold very precious liquids. Now, this ampulla vata, it holds 2 of the most precious body fluid, the bile juice and the pancreatic juice. And basically, it's a misnomer actually. It's some people call it ampulla vata, some people call it a papilla vata. But technically, papilla is the mount of ampulla, and ampulla is the entire bulky portion of the thing that we see in the duodenum. Now, I'll just show you the thing. Actually, see, basically for any ERCP, we require technology, technique, technician, but we have to understand the ampullary anatomy, optimize the ERCP suite, and also you should understand the body language of the endoscopist during the entire procedure. So I'll just show you a couple of landmarks: ductal anatomy, sphincter anatomy, muscular anatomy, blood supply and venous drainage and lymphatic drainage, which influence this. Now, if you see this ampulla is located about 7 to 10 centimeters from the pylorus. And whenever we have any pathology in the first part of the duodenum or in the uncinate pathology, this papilla gets pulled up. And whenever we have some pathology in the pancreatic head, this papilla can be pushed down, and rarely this can be in the third part of the duodenum. So the pathology in the duodenum or the pancreatic head can alter the position of the ampulla. Second, where does this locate? Actually, it is found where the longitudinal mucosal fold meets the transverse mucosal fold. This is the commonest position which is seen in almost 60% of the subjects. Now, this is very, very important. Actually, that is the orifice that is called as the papilla as in today, the longitudinal mucosal fold and the transverse mucosal fold. These are the transverse mucosal folds, the circular folds. This is the duodenal papilla, and this is a covering fold on this. So, the ampulla vata can be in different shapes and sizes, and basically it is called as the fingerprint. Actually, if you saw, the fingerprint is so different in each and every individual. The ampulla is equally different in each and every individual. Now, whenever we have this scope, whenever we are doing this ERCP, it is done between this long position or a short position, like this. Now, irrespective of the long position or the short position or the via media position, the ampulla has to come in the upper quadrant of your monitor between 9 and 3 o'clock position, preferably at between 11 and 2 o'clock position. Now, these clock positions are very, very important. Actually, they keep repeating over and over again in ERCP. Ideally, the papilla or the ampulla should become somewhere between 11 and 2 o'clock position. Even when you have this short position, you make sure that the ampulla is in that between 11 and 2 o'clock position. Now, if you see this is how it is. You mark the thing here, upper outer quadrant, and then you can see that the ampulla has to come for that. This is for the standard Olympus scope, depending on the position of where the catheter comes out of the scope. Now, we also understand that actually the MRCP is mandatory in most of the therapeutic endoscopy procedures. It tells us the terminal CBD anatomy, and you should be able to perform ERCP better if you have a good 3D reconstruction of the before you do the procedure. Again, you can see that it has to come somewhere between 11 and 2 o'clock position. Now, this is the most important thing. I think when we're writing a textbook, I think we should write. Now, suppose if you're doing ERCP in a prone position, this is the table position. This is the endoscopist who is standing. Now, the endoscopist has to stand at a 45-degree angle to the table. If he is facing the endoscope table, then the chance of the scope slipping out of the duodenum is very, very high. In this position, to keep it, the monitors have to be in this corner so that you'll be able to visualize, and the assistant stands on this side. So if you're standing absolutely parallel to the thing, I'll show you the picture. So when the table is like this, you're supposed to stand about 45 degrees to the table. In this position, the scope is absolutely in a straight position. Otherwise, you have to hold the scope in a very awkward position to do the cannulation. This is an optimal position wherein the scope will not slip out of the duodenum once you have cannulated. I hope I'm very clear. This is 45 degrees to the table. The monitors on the opposite side. This is very, very important to prevent any strain on the neck. Otherwise, you keep turning your head in opposite directions and it strains your neck too much. Now, suppose if the patient is in supine position, you understand? Now, to get the same position again, you see the amount of body habitus that you have to change, and this change in the body habitus exposes you to the radiation from the back. So the moment you have turned the patient to supine position to do an ERCP, these monitors have to come onto the opposite direction. You can shift these monitors from this side to the opposite side so that you don't strain your neck during the entire procedure, and also your back is not exposed to the radiation. I hope you can see this very, very clearly. When the patient is supine, you turn your table onto the opposite side so that your back is not exposed. This is very, very important. Actually, it saves a lot of physical trauma to this. Different types of papilla, type 1, type 2, type 3. Type 1 is the commonest one where both the things open here in an ampulla-like thing here. Type 2, wherein both the ducts open quite close to the papilla here. And type 3, where both of them open separately. Now, this papillary orifice, now normally it is like this. Now, if we have to cannulate, this is slit-like. If you have to cannulate, the basic trick is use any sphincterotome, push this mucosal fold upwards. So this slit-like opening on the papilla becomes oval, and it is easy to pass a guide wire. This is a very simple technique that can be practiced. The other thing is, if you are not able to localize the papilla, the opening, you can spray some methylene blue over the thing and wash it out, and then you can see the papilla, the orifice becomes very, very clear as compared to the surrounding. These are some technical tricks that can be used during ERCP. And whenever we have this orientation of the duct, you can always see where you have the papilla, the ampulla bladder, the common bile duct is in the 12 o'clock direction, and the pancreatic duct is in the 1-2 o'clock direction. Now, if you say the cross section of the ampulla, this is the cross section of the ampulla of the duodenum. Now, you can see this is the ampullary mound here. Now, the green structure is the bile duct, and the yellow structure is the pancreatic duct. You see the histology of the same thing. That's the bile duct, that's the pancreatic duct. Now, as you see this, actually, as you go from the papillary orifice towards the duodenal wall, these bile duct and the pancreatic duct get separated. And you see cross-section wise, at the papilla, both of them like this. But as you go away from the thing, both of them get separated. This is very, very important to understand. Even an endosono, you can see that this is how they get separated. Both the pancreatic duct and the bile duct get separated. Now, I'll skip this. Now, whenever, based on that anatomy, depending on the pathology in the papilla, the openings get separated. You can see this in a periam. Normal, this is how it looks. In a tumor of the ampulla of Vater, if it is like this, you understand usually what happens whenever we have a tumor involved in the ampulla, both the ducts get separated basically because of the tumor. And cannulating a periampullary tumor is far more easier than cannulating a normal papilla, basically because both the ducts get separated and the bile duct is at the upper end of the deformed tumor and the pancreatic duct will be somewhere at 1 2 o'clock position. Again, if you see this cross-section, MR cross-section, you can see this, how the pancreatic duct and the bile duct get separated. And you can see this is the ductal separation that happens. And this is the periampullary tumor Whipple specimen to show that this tumor separates the pancreatic duct and the bile duct completely here. So it's very easy to cannulate a periampullary tumor. Now, this is very, very important actually. The ampulla of Vater gets the blood supply from the retroduodenal artery here. There are two main vessels actually, one at 5 o'clock position and one at 7 o'clock position. Now, these are we have a lot of anatomical data to show that. You can see this. These are the 2 points where we have major vessels in the ampulla. So, suppose you cut anywhere else, you'll not have any major bleed, but 5 and 7 are the major vessels that supply the thing. And we have beautiful articles to show the blood supply of the ampulla of Vater, and the main vessels are usually at 5 and 7 o'clock position. And they also data to show the CAS data to show the blood supply of the ampulla. This is just to show you the same picture. Right. This is one of the ampulectomies being done. You can see this. Just to show you where the main vessels are, they run at 5 and 7 o'clock position. So basically between 3 to 9 o'clock position, there are hardly any major vessels. You can see there's an ampulectomy done, and you can see this major spurters that are coming from 5 and 7 o'clock position. That's the bile duct there, that's the pancreatic duct there. This is essentially very, very important to know that basically because catastrophic bleeding occurs only when we do ampulectomy procedures like this. But when we do sphincterotomy, majority of them, this is the relatively avascular area between these two areas. So the bleed that happens during sphincterotomy can be easily controlled during with any of the accessories possible. I hope you can understand that this is the majority of the time you have cut satellite like this at 5 and 7 o'clock position. So the least avascular area is between 3 to 9 o'clock position. I'll show you for even the venous plexuses actually, there is pre-superficial plexus and most of the bleed from this can be controlled easily. The third important thing that we have to understand is the sphincter anatomy. Now we have this sphincter of ampulla, this is the sphincter of Oddi here, which engulfs both the pancreatic duct and the bile duct. And there are superior and inferior choledochal sphincter and a pancreatic sphincter. Now the main reason why this, and whenever we are doing a balloon sphincteroplasty, now these two are the sphincters which have to be dilated. Now we are doing this pre-cut actually. Now the most important thing is why do we put stent when we have doing post ERCP to prevent post ERCP pancreatitis is when we're doing this cannulation, this pancreatic sphincter goes into spasm and the pancreatic juice does not drain and it causes pancreatitis. So the main reason, one of the reasons for putting in a pancreatic stent if you're cannulating more than 3 times is to prevent this sphincter going into spasm so that to prevent post-ERCP pancreatitis. So likewise, you can see this pre-cut is other thing, and just last 2 slides I'll just show you. Pre-cut is other thing that we use a needle, non-needle knife. Now based on all this anatomy that we have this axis of the bile duct. Bile duct is at 12, pancreatic duct is at 2, 3 o'clock position. Both the ducts get separated as they go towards the duodenal wall. The vessels are at 5 and 7 o'clock position. These are the sphincters that are on the pancreatic and the bile duct here. Based on this, if you see this, the ductal orientation is like this. The blood vessels are at 5 and 7 o'clock position. The safest area to do the pre-cut or the sphincterotomy is at between 11 and 1 o'clock position. I hope you can understand. This is the reason why they keep saying you have to make a pre-cut or a sphincterotomy in this direction. If you make a cut, anything lateral to this, you're likely to injure these vessels and can cause this side if it can cause pancreatitis, the other side it can cause bleeding. Now, this is again, there are a lot of ways to do it. Actually, some people do it from below upwards, some people do it from above downwards. I practically believe, because as a surgeon, whenever we make a surgeon incision, we make it from upside down. So whenever we're doing a pre-cut from below upwards, this needle tip takes the mucosal fold along with it. And the short burst of diathermy that we use can induce pancreatitis. And this is what happens when you lift the fold. But if you're cutting it from above downwards, what happens is the entire duodenal mucosa gets effaced and there is no damage here. So whenever we're doing a pre-cut like this, so we're doing a pre-cut from above downwards, the mucosal folds are effaced. You're not cutting the orifice, the papilla we are not cutting, we're away from the thing. So the pancreatic duct is spared. You're cutting in the mound at the 12 o'clock position where the bile duct is, the pancreatic duct is somewhere here. So by doing a cut from above downwards, we're cutting it absolutely layer by layer here, and we cannulate the bile duct here, avoiding the papilla and the pancreatic duct to prevent post-ERCP pancreatitis. You can take any number of these examples. You can see this. This is the ampulla here. We're cutting it from here. We are avoiding the cut extending onto the papilla here. We avoid that so that we don't cause pancreatitis. Same, here you can see this is the opening here. We avoid this area, make layer by layer, you cut into the thing and get into the pancreatic duct. So, like this, actually, you see, this is ideal to know that pre-cut is whenever we have an impacted stone, we can practice this either from below upwards or above downwards. But to learn, I think, an impacted stone, or whenever you put a pancreatic stent, you can try this doing a pre-cut of the pancreatic stent. See, like this, actually, huge pre-cut done from above downwards. And this is the large periampullary tumor, you're not able to get access. And this is called, this is again a periampullary tumor, huge bulging into the thing. Then we make a cut in the ampullary mound here and then get direct access into the pre-cut. Even in intradiverticular papilla, we should be able to do this very, very safely as long as the mucosal folds are effaced, and we should be able to get directly into the papilla. So if you don't understand the anatomy, this is what happens. You can understand all this battered papilla you have. Whenever you're doing this pre-cut and if you're not able to cannulate, please wait for 24 to 48 hours. Do a repeat ERCP again, then we should be able to cannulate. Thank you so much. I'll listen to the other presentations, and if there's anything else, I'll add to the things also.
Thank you. Thank you, Professor GV. I think we'll go for the next question. I think Dr. Ishwar, you can go for the next question.
Can we stop sharing GV? Let me see whether I'll be able to share my screen. Thank you. I think not only GV has given an insight into the 3D anatomy and its applied aspects, clinical application, how understanding anatomy helps you in various difficult situations, nicely has demonstrated. So let me come to the other problem. Very often when we do ERCP, the first thing we notice is there are a lot of large periampullary diverticulum. Are they going to be hindrance or innocent bystander is always a dilemma. And I can ask Professor Praveen Suryavanshi, what do you do when you see a diverticulum and along with that an ampulla is there, and what is your course? How you manage such situations, and what are the changes in your practice you do in order to get a successful cannulation?
Yeah. So thank you so much, Dr. Govindraj and all his team members for hosting such a wonderful activity and for this opportunity for us to participate. So as mentioned by Dr. G.V. Rao, that there are many techniques and tricks to overcome all these difficulties. As far as you know, these diverticulums are seen in almost 15% of the patients
who come for ERCP. And there are three types of diverticulum commonly described. Type 1 is where is the ampulla is inside the diverticulum, which is the most difficult situation to achieve successful cannulation. Second type is it is at the edge of the diverticulum. It can be either on the right edge of the diverticulum, which is or on the left edge. Right edge, I feel it is comparatively easier to cannulate as compared to left. And third, it is away from the diverticulum. So, as mentioned, that the type 1 is the most difficult situation. So, depending upon the location of the diverticulum inside the, this papilla inside the diverticulum, if it is at the roof of the diverticulum, then it is comparatively easy roof and the floor, but it is on the side wall of the diverticulum. Sometimes it is deep inside and with a narrow opening in the duodenum. Then it's really sometimes become difficult even to identify this papilla. But if it is at the floor or roof, then it's easy to identify also and easy to cannulate. Dr. Jivera has shown one video where when the diverticulum was at the floor of the papilla was at the floor of the diverticulum, even he could do pre-cut sphincterotomy. So what I do if the diverticulum is not accessible, sometimes it is looking papilla is not accessible inside the diverticulum. What I do, I inject saline at the upper edge of the diverticulum. Never inject at the lower edge. If you inject at lower edge, it further becomes it disappears. Always inject at the upper edge so that the papilla bows down towards you, and then it becomes easy to cannulate. Only thing you must make this change of accessory very fast, so that before the saline get absorbed, we should able to access the papilla. Second option is that what we can do with the biopsy forces and all that, we can see the pool of mucosal folds inside the diverticulum. We can catch those mucosal folds and pull the mucosa outside the diverticulum in an attempt to see the papilla and we get the access. So sometimes we will be successful to see the papilla and get the access also. Another thing that the scope has to be in very stable position if you really want to get successful cannulation in the periampullary diverticulum. So that can be achieved as mentioned by Dr. G.V. Rao that in many situations if there is a tumor in the especially in the uncinate process, it pushes further this papilla upward and becomes situation more difficult. So in that situation only you can try with the long axis for the successful cannulation in such a situation. Only precaution that what everyone should follow, especially the beginners, that you should not do extended sphincterotomy or sphincteroplasty in such cases, especially when the diverticulum is inside, this papilla is inside the diverticulum, because there are high chances of perforation and bleeding. So that is the only precaution you should take. Otherwise, with experience and it's not difficult in every case. Only I feel in a maximum 10% of the cases, even experienced endoscopists need to struggle. Otherwise, most of the cases is a easy situation. That's all.
Excellent points, all of them. Thank you, Praveen. Let us go to the next question.
Thank you, Praveen. And next question is to Dr. Bhavneet Ballar. See, in a ERCP, it's always a teamwork. So I would like you to stress on or your understanding or how the importance of communication among your staff, your anesthetists, your technicians, how important it is to communicate with them, and what is your tip for the youngsters to help?
Thank you, sir. Thank you for the question and inviting me to be a part of this esteemed panel for the discussion on ERCP. So to my mind, I think ERCP is one of the most team-dependent procedure in GI endoscopy. And so it's absolutely critical to have a good coordination and understanding between the endoscopist and his or her assistant. If this communication is lacking there, then even a simple case of ERCP sometimes turns out to be very difficult to do. And actually difficult and a challenging case may actually end up being a failure. You're sometimes not able to do that. But on the other hand, if you have a very good understanding and communication, then it not only increases the success rate, but it also reduces the unnecessary exposure to fluoroscopy, reduces the overall time of the procedure also. If I have to just tell you what kind of a coordination and communication I'm talking about, it is basically as if a car is driven by two drivers, one who is controlling the steering wheel and the other person is in charge of the accelerator and the brake and the clutch. So if that car has to move safely, there has to be an absolute level of understanding between the two persons. And this communication doesn't have to be in the form of a continuous dialogue or a series of commands being given by the endoscopist to the assistant. In fact, the communication has to be very clear, calm, and precise. So when I am doing a ERCP procedure, in fact, my communication is most of the time in the form of simple keywords. I would probably be just saying elevate or bow, now inject, inflate, advance. And my assistant basically understands what I'm asking from him. So, and sometimes if the case is really, I have the communication becomes even more subtle. So it is almost to a telepathic level that he'll probably be just looking at my frowning face and probably understand what I want now and where I'm struggling and what he can do. So the point is, a good assistant is a very important resource in doing a successful ERCP, and it's not only about the technical skills, but it's actually more of a teamwork. But having said that, this level of communication and understanding will not come in a day or even a week. So I have been lucky to have the same assistant for the last 8 to 10 years. So probably that is something which is very important, to start with the team and then stick to the team so that everybody grows together and that level of understanding is possible. So I think that's the
Thank you.
key message, to have a well-trained assistant by your side.
Thank you. Thank you,
Thank you,
Bhavneet.
Bhavneet. That's wonderful. I think the basic take-home message is just by eye gestures, your assistant will know what you exactly need. Like in surgery, your assistant gives the instruments. Yeah. The next question, I think.
Yeah, this is regarding the fluoroscopy. We use fluoroscopy quite frequently, either an image intensifier or a CR. Let me put the question to Govindraj himself. And what care you need to take care of the patient's safety regarding the radiation, and also your own safety and your own staff's safety.
Yeah. Thank you, Ishwar. I think basically, I think everybody knows what fluoroscopy is. Fluoroscopy is nothing but an X-ray. It comes in a pulsed form. There are the previous fluoroscopies had an image intensifier. Now the latest have a flat panel. So in fact, the radiation has come down compared to what it was. If, the image here is what you see is an image intensifier. Now the new ones have the flat panel where the radiation dosage is much less. But basically, there are two things you have to understand. One, protection to the patient, and protection to the surgeon and your support staff, whomever you have. So there are three things which I would like to understand is one is the time, and the other one is the distance from the equipment and the distance we are standing, and what are the shielding what you are using there, like whatever it has been pointed there. So if you look at the time, so reduce the time of fluoroscopy. So you don't give a continuous fluoroscopy. You always use a pulse method and use fluoroscopy only when it's necessary. Don't use a continuous mode and try to avoid that continuous mode. And on latest equipments, they always have this hold nature. The last image can be held so that you can see what you have seen the last. So this is very useful, called the hold feature is always there in the newer equipment. And the distance between the image and the X-ray tube and the distance you stand, definitely it's useful to reduce the whatever exposure you are getting. So stand as far as possible away from the X-ray tube. Even a small distance also increases more protection there. And of course, proper positioning of the patient is also very important in this. So always keep the X-ray tube below the patient and as far as possible away from the patient. And the staff should stand closer to the detector rather than the X-ray tube. And these are all very small points which are very useful. And never keep your hand in between the beam. That also reduces the exposure. And having proper protection. The lead apron you wear here, the lead apron thickness should be at least 0.5 millimeters. That's very important. It should be at least 0.5 millimeters. And particularly when you have women around you, there should be definitely ovary protection should be there. There should be thyroid protection should be there. And goggles should be worn, lead glass goggles should be worn. And these are very, very important. And if you are a avid user of this fluoroscopy, nowadays there are people who use lead gloves also they use. And so these are the basic things which I require that should be definitely kept in a fluoroscopy room or in a room where there is ERCP is being done.
Thank you. Thank you. Excellent insight to the thing. You
Can I
take
add?
the question.
Yes.
Hello?
Yes, sir.
Praveen.
Praveen, sir. Praveen.
Yeah. So what is one more thing which is, it was shown in the picture, but it is important to mention also that we must wear this jacket and the skirt type, this leader appearance, not
Yes.
the like front loading type.
Yeah, front load.
Because whenever you're doing supine in ERCP in a supine position, as Dr. Jivira was shown, that we turn and we back faces this fluoroscopy, and then from there we are at risk of exposure. Always wear complete jacket and the skirt type, this lead apron. And so it helps in two ways. It less chances of getting exposed. And second thing, if you are a beginner and if you need to do ERCP for hours together, it share the loads. Whole loads doesn't come on your shoulder. You don't get that fatigue, factor. So that's a suggestion. And another important thing that leak test has to be done at least twice a year. So there are standard protocols how to do that. Everyone must do. I did, audit in our city, and we found that the 70% of the lead apparents they were not, in good condition. So I think that is the important message we must, share with our colleagues that the leak test has to be done at least twice a year.
Thank you. Thank you.
And one more thing also, I think, as you said, we should all wear those personal collimeters. Dosimeter, exactly.
Yeah.
Dosimeter should be worn, and that should be worn outside the
Lead.
Yes, exactly. That's very important, and that should be given for the AERB for every year for calculating the how much dose you have received in 1 year, so that when it goes above certain limit, you will be given some period of a holiday to come out of that.
Yes.
That's important part. Yes, thank you. And the next question is on positioning of the ERCP. I think this is a question towards Dr. Praveen Churavanshi. What do you think would be an ideal position for an ERCP, and which are the positions you usually do?
Yeah. See, ideal position as far as beginners is concerned, Dr. Rao has already mentioned that the supine position is the ideal, prone position is the ideal position where complete, patient is upside down and the neck is tilted, face is tilted towards the right side. So this helps in, easy straightening of the scope, even the papillary position and the, cannulation become key in this position. And not only that, the imaging on fluoroscopy is more anatomical, and there is no overlapping of the bony shadows in this position. The only problem with this position is that it may not be possible in every patient, especially if the patient is very critical, already on inotropes, or patient is already intubated, or obese patients, or patient with neck problems. In that situation, we may have to give supine position. So in that case, the cannulation become little difficult. There is a chances of excessive insufflation of the stomach that we have to avoid during that position. And in our practice, best position is, once you are more well versed with the handling of the scope, I think semi-prone position is more, practical, because the marginal high risk patient we can manage in this semi-prone position. With in that we just lift the shoulder, patient shoulder and the hip by 20 degree, so that patient can breathe comfortably and the airway access to the anesthetist is accessible. So borderline up to grade 3 cases we can comfortably manage in semi-prone position. So in our practice, this is the semi-prone position is commonly we use.
Thank you. Thank you. And the main critical point regarding ERCP is, of course, not just selective cannulation, but reaching the ampulla from the oropharynx all the way. Especially people, beginners, not used to the side viewing from the beginning, they'll have their own challenge. Can I ask GV, what is his tricks? Can I tell in plain English how we can take it from oropharynx and how he is able to reach to able to bring the ampulla exactly where he mentioned around it? Top upper part of the monitor. Over to you, GV.
See, this is the most important thing, because the scope that we're using is a side being scope and not an end being scope like in conventional endoscopy and colonoscopy. Now, most of the people say that intubation and is passing the scope of a side being scope into the duodenum is a blind procedure, but no. The only part, the difficult part, is passing the post-record area could be blind. But once it is in the esophagus, we have to tilt the scope slightly upward so that you are able to see the lumen slightly. You will not be able to see the lumen completely, but you cannot pass the scope blindly into the stomach. You have to know that you're going in the tract. So you're not getting a complete luminal visualization, but you get a part visualization of the tube, and then you come at the G junction. Now from here, umpteen number of endoscopies keep talking about right knob, left knob, up and down and position. All this is a big confusing language. I don't think there's any this thing actually. The best part of the thing is you have to know that you have to go along. You lift the bigger knob. You make sure that you put it down so that it faces like a hand like this. You are able to see the ampulla, the orifice, then the pyloric opening. In this direction, you're supposed to go along the lesser curvature. That is what happens actually. So you have to go just do the big knob down so that this scope becomes slightly like a snake. Then you will be able to see the pyloric opening, and then you can go along the lesser curve. Now, once we reach the pylorus, there is a semi-blind procedure. Then you take the scope, make the scope into the neutral position, get into the D1. Now here, once you get into the duodenum, now the position is here is where you turn the small knob to the right, and that takes the scope at the D1, D2 junction. It goes into the second part. Now here actually Ishwar, I think, actually put it in the duodenal cap here. If you have the next this thing, actually you know that you're turning the right knob into the right ear. Yeah, absolutely. Turn the right knob right, and then that slips into the second part, and then you shorten the scope there. So basically, we have to understand that actually you have to go slightly blind at the post-cricoid semi-blind in the esophagus, make the bigger wheel down so that we'll be able to see the pylorus from a distance, traverse along the lesser curve of the stomach, semi-blind entry into the duodenum into the pylorus, that is where you turn the right knob right to get into the D2, and then you fix both the small wheel, and then you withdraw the scope slowly so that you follow the longitudinal fold go up to the transverse fold. By the time the scope also gets shortened, and the papilla will be right in front of you. So this entire maneuver has to be done with your position almost about 45 degrees to the table, so that the scope does not slip off the duodenum, and even your hand is absolutely perpendicular to the body, so that the axis can be passed very easily.
Thank you. Thank you. A great explanation, GB.
Yeah, I think the next question, I think since Amol is not there, it's the evaluation of the papilla prior to cannulations. And here I think I will take up this question. See, basically, what is the classification of the ampulla that's commonly used is the Haraldson classification is being used. There are, according to the Haraldson classification, there are 4 types of cannula, ampulla there. And usually the type 1 is a very regular one and very simple one, what you see here on the left side. And this one is quite easy to cannulate. The easiest among all the 4 types, it's the easiest one. The type 2 is the one you see here second, which is a small cannula, a small ampulla where it is less than 3 millimeter in size. And it is a little difficult to cannulate compared to the type 1. And type 3 is the one which is the protruding one. This is a type 3 is also difficult to cannulate. And type 2 and 3 are almost equal. If you say it is around 20 to 30% difficult cannulation. And type 4 is called the creased type. Here you have a creased type, and it is supposed to be one of the most difficult to cannulate. According to the studies, they say more than the creased one is almost 40% difficult to cannulate. Apart from this, there are a lot of clinical factors also are important, and the endoscopist factors also are there in difficult cannulation. In high volume centers where they do at least, each individual can do at least more than 200 ERCPs per year, the cannulation is easy for them. Where in the reverse, if you say an endoscopist who does less than 200 ERCPs per year, they find very difficult cannulation most of the time. So this is one of the levels of endoscopy training what he has undergone. And apart from that, the clinical factors, when there are no cholangitis and when there is the bilirubin is normal, there is always a difficulty in cannulation is there because the bile duct is not dilated. There is always a difficulty in cannulation. So it becomes a difficult cannulation. And so these are the few things I would say how the difficult the papilla is and difficult in cannulation. And already Dr. Praveen has explained about the diverticulum and its difficulty in cannulation. Thank you very much.
Thank you, Govindraj. Let's go. There are occasions like when we do a lap appendix, the appendix is not in the expected position. Same way, you are in the D2, but you're not able to see. The ampulla is not staring at you, and you're a little anxious. Where is this hidden? So, what will you do, Bhavanit, in those situations where you're not able to see clearly where is the major papilla? What is your protocol? Is Bhavanit here? Am
I audible now, sir?
Yeah, you're audible. Thank you.
Sorry, I was on mute. So what I was saying was, sir, the first thing when we do is when we enter into the duodenum and we try to straighten the scope tip actually advances further forward into the duodenum. So we usually end up slightly going beyond where the major papilla is usually located. So it should not be an alarming thing at the very beginning that I don't see the papilla. What you need to do is basically first bring the scope in the correct position, in the short loop position. And then you actually expect to see the papilla, which is usually located around 8 to 10 centimeters distal to the pylorus, medial wall, and you expect to see it in the upper half of your screen between 9 and 3 o'clock position. But having said that, sometimes it is not very obvious for various reasons. And so the first thing which I usually do is I start by suctioning if there are a lot of secretions in that area. And then I actually look for that longitudinal fold or the frenulum. So I can see that the frenulum is actually the only longitudinal fold. The rest, all folds are horizontal or circular. And I trace that from below, and it will usually take me to the T junction where that frenulum actually meets the first horizontal mucosal duodenal fold, and that is usually where the papilla is located. And I sometimes try to do suctioning also if the papilla is not very obvious, and I try to look from where the bile is trickling out. These are the small things which I do, but sometimes the papilla is actually hidden. In spite of doing all that, we don't see the papilla in the second part on the medial wall, and this could be because of the variation in the anatomy. In the last slide, it was shown beautifully. We have 4 types of papilla, and the fourth one usually is, or what we call it, the sharp-eyed dog papilla, in which there are lots of horizontal duodenal folds which are sort of hiding or overhanging over the papilla. So the first fold, which we refer to as the hood of the papilla, the first horizontal duodenal fold just above the papilla is the hood. So sometimes that could be overhanging and hiding the papilla. So what I do is I usually just bow my sphincterotome and try to lift that first horizontal fold up, and I usually find that the small papilla is hidden underneath it.
Thank
And
you.
then
Thank you.
papilla
Excellent, useful points.
could be hidden inside the diverticula also. And Dr. Praveen sir has already mentioned with various steps to how to locate and then try to cannulate that papilla depending upon where it is located in the diverticula. Other causes could be, it could be a case of a surgically altered anatomy. Then we usually don't expect to find it at 12 o'clock. It is usually around 6 o'clock. And could be a case of a periampullary growth. And Dr. GV sir has already mentioned that it's actually rather more easier to cannulate the CBT because the growth itself is going to separate the two ducts. One last thing which I try if everything else is not working is I try to do a cap assisted ERCP, and that sometimes helps me to actually locate the papilla. That's
Thank
something
you.
else I can try.
Excellent points. Excellent points. Thank you very much. Govindaraj.
Yes. And the next question is for Dr. Praveen. And selective bile duct cannulation. And what are the tips you would advise, and what are the tricks you follow?
Yeah, again, to begin with, patient position, at least for the beginner, that prone position is better position to get proper access to the papilla. So in prone position, scope is also nicely straightened up, and so that the position of the papilla should be between 11 o'clock to 1 o'clock position. And as it is shown in the picture, if it is like upward trajectory, then you can use normal sphincterotome. Without bowing, we can access the ampulla. But if because of some whatever anatomical variation or the pathological distortion is there, if you are not able to get this upward projection, and your scope is facing ampulla in a horizontal way, then you can go a bit your sphincterotome, and we can try to get that axis of trajectory axis for the selective annulation. Sometimes, as mentioned by Dr. G.V. Rao, that for the if you get proper trajectory, also, you can go the introtome and lift the ampulla to get access into it. If still again at the beginner, if not able to annulate the ampulla, then we can try with the thinner guide wires like 0.025 guide wires. You can try, and most important thing that you should not attempt too much. It is a rule that 5 minutes, 5 attempts. If you are able to cannulate, you should do that. Otherwise, you must opt for another advanced technique of selective cannulation. Because more you attempt, more this ampulla get injured, and there are high chances of creating false passages. There is edema of the tissue, further obscure the lumen, which makes it further difficult. So before the papilla get tense because of the injury or edema, before it starts bleeding because of the injury, you should, and before your team get exhausted, you should get into the count bile duct. That should be your target. I think that's all.
Thank you. Thank you, Praveen.
Thank
In
you.
the same way, sometimes when we really wanted to do a bile duct cannulation, every time the guide will go into pancreatic duct. But actually, when we want to have a selective pancreatic duct cannulation, sometimes it will be very daunting task. Sometimes. So I ask GV how we can go. I want to go into pancreatic duct. How you make it happen from the word go? What is your tricks?
This is very, very actually there are two, three things actually. One, as I told you, actually the position of the ampulla should be absolutely in the upper outer quadrant of your monitor. Two, you should give some amount of antispasmodic to make sure that the bowel is free from contraction so that you'll be able to see the thing. Three, never ever try to poke the papilla the moment you see the papilla, because the moment you start poking it, it goes into spasm and you'll never be able to cannulate. Four, always never use contrast to inject into the pancreatic duct to the bile duct directly. As of today, the standard of cannulation is only with a sphincterotome and an O25 thermoguide wire. Or if you have a jaguar which has got a stiff wire with a thermo at the tip. Now, these are basic things that I think we should all know, that actually unless and until we do this, actually we should know. Three, actually the pre-ERCP prophylaxis, actually especially high-risk people like young females, people at high risk for post-ERCP pancreatitis, lower bile duct, hilar obstructions, all these patients should get rectal indomethacin as a mandatory, either at the induction or it is 30 minutes before. Hydrate the patient adequately before you attempt ERCP. As Praveen has very clearly told you, actually, most of the time, actually, whenever we're trying to get into the thing, it is not because why we get into the bile duct, pancreatic duct the moment you try to cannulate is basically because you are not allowing adequate time for the papilla to open up, and then you're trying to put the thing at the commonest orifice, and basically because, as we shown in the anatomy, 90% of the time both of them open into the same common orifice as the tip. The moment you put the thing, basically because of the angulation of the thing, it goes into the pancreatic duct. So suppose if you have to cannulate the pancreatic duct, the position has to be an inch proximal to the regular bile duct cannulation. In the sense, we have to withdraw the scope slightly an inch so that the angulation of the scope is not in 12 1 o'clock direction, but it is going in the 2 3 o'clock direction. So it has to be facing slightly downward, and in that direction, suppose if you are able to put this thermoguide wire in the sphincterotome, you should be able to get into the pancreatic duct. Now, see, all the time we keep talking about you want bile duct, you enter into pancreatic duct, you develop pancreatitis. But when you're trying to get into pancreatic duct, if you get into bile duct, it doesn't cause any major problem. But if you're repeatedly getting into the bile duct, then the only option would be to put a stent, do a sphincterotomy. Once you do a sphincterotomy, then the pancreatic duct orifice becomes more easier and you can see the thing very, very clearly. So standard rules actually we have to practice. No more catheter cannulation as in today. No more contrast cannulation. It is always a sphincterotome with an O25 guide wire as in today. That is the standard of practice as in today.
Thank you. Thank you. Excellent practical point, GV. Let me ask this question to Govindraj. I
Yes.
think GV has already explained his
Yes.
way of doing a pre-cut. What's your way of doing pre-cut, Govindraj?
Actually, the pre-cut is only done when you are not able to cannulate, and you use a needle knife. And already GB has explained much, but there are certain guidelines when you do a pre-cut, and particularly these guidelines have come out of the consensus of all the endoscopists when you start doing a pre-cut. Usually, they say around 5 to 10 minutes of active cannulation you have been doing when you're not able to cannulate, or when there have been more than 5 attempts to cannulate and you are not able to cannulate, or when there are more than 2 attempts, that is at least 3 attempts where you are cannulated into the pancreatic duct, then immediately switch over from trying to cannulate into the CBD to do a needle papillotomy or needle sphincterotomy. So this is when you do it. So how you do it comes is how you do it is, as I think Dr. GV has already explained in detail. You do a papillotomy is from the roof you start coming down using the needle knife, or when you want, that is called a fistulotomy, needle fistulotomy or NKF, or when you want to do a needle papillotomy, you start from down and then you cut across and go to the roof. And these are the basically two different techniques in which a needle papillotomy or a needle fistulotomy is being done. Thank you very much.
Thank you. Thank you. I think now we have
One more
discussed all
practical
the.
tip actually, whenever we're doing recut, actually, the needle knife that is marketed completely comes, if you use its fresh needle knife, it comes perpendicularly out of the thing. If you're using a perpendicularly coming out needle and you try to cut, the depth of the cut is more. So make sure that you prime the needle in the direction of the curve of the catheter. I hope you can just prime it.
Yeah, yeah.
So the tip is not perpendicular, but it is slightly curved. That way, you avoid a deeper cut into the ampulla, and also very small ampullas when we're doing, we avoid the deeper cut into the thing actually.
Thank you, sir. Thank you.
Thank you. Thank you.
Important point.
Yeah. Now coming to the now technical aspects over. Now we are going to have a short answers, like 30 seconds answers with the time constraint. Your choice of sphincterotome and guide wire for a routine ERCP case, Praveen.
Yeah, again, as far as sphincterotomes are concerned, there are two options. We are either long nose or a short, small nose. So if the papilla is, as mentioned by Govindraj, is type 1 or a type 3, then I prefer to use long nose. But if this type 2, where is the flat papilla, then I prefer to use short nose. Again, as I mentioned, the beginner should use, even we are in routine practice, we start with the sphincterotome. We never use plain catheter for the initial cannulation. Second thing, guide wire again, for the initial cannulation, Termo is the very gold standard. Everyone using Termo, and we have two options, whether straight tip or the angle tip. Again, preferably initially we should use, in almost in 90% of the cases we can manage with the angle tip Termo guide wire. Only thing, what is the most important trick is that the guide wire should be wet complete throughout the insertion and the manipulation. It should never be dry at any point. If it becomes dry, then it loses its benefit of this hydrophilic and the torque you will never get. So that's the most important trick. And as far as this exchange wire is concerned, there are many options. I'm using this Olympus Clever Cut. I'm using the Easy Guide. So I prefer to stay with one company so that the inventory management is not an issue. Otherwise, there are many good exchange wire in the market. And balloon basket, I think, even Indians are good as far as, if you are really concerned about the cost cutting. So I'm happy with that. Even stent also, many Indian producers are there and using them, plastic stents.
Thank you. Thank you.
Thank you.
If you ask me, actually, any sphincterotome is okay. Short nose, blunt thing, actually. If you are doing advanced procedures, Termo is important. Otherwise, zebra wire or a command wire is okay. Baskets, as far as I am concerned, strict no in clinical practice, especially if most of the surgeons are not fully equipped. So baskets are likely to get impacted, especially after the balloon sphincteroplasty has come. Please do not use baskets to remove CBD stones. Okay, this is a blanket statement because balloons can remove most of the thing. Balloon sphincteroplasty removes most of the thing. So there is, as far as I'm concerned, there is no role for using baskets to remove CBD stones in current day practice.
Thank you. Thank you.
Thank you, sir. Thank you. And Bhavani, I think we all talk about 0.35 and 0.25. Please explain what is 0.35 and 0.25, which is your choice. And of course, as Dr. GV said, the importance of thermo in your armamentarium.
So we are basically referring to the diameter of the guide wire, sir, here. So if I share my experience, my go-to wire to begin with is a 0.035 inches wire, sir. And this is what I usually start my cases with. And if I assess that it is a normal shade papilla and it is a routine case, so I find this wire to be very satisfactory. And then there are all the other aspects which an endoscopist needs to understand: straight tip, J tip, S shaped tip, and the length of the wires also standard. If you are planning to exchange your instrument, then most of these wires are usually 440, 460 centimeters. Although there are certain other assemblies, there are gadgets which will allow you to use a short wire also around 260 centimeters. But routinely, I use a 0.35 inches and a 460 centimeter long wire. It is very easy to handle. It has a hydrophilic tip, and the torquing effect is really good in this. It has an adequate amount of stiffness also, and that makes it very easy for us to exchange our accessories over the wire and also deploy the stent also. But having said that, supposing I'm stuck with this and I'm not able to do a selective cannulation, then my next option is to switch over to a 0.025, especially when I'm looking at a case of a hilar stricture or a tight CBD stricture, or when I'm planning to do a pancreatic duct cannulation. And if everything fails and I'm still stuck, then thermo is actually for me my reserve or the last option for me. It's my reserve wire actually. So then basically it's a long, flexible, very flexible, soft tip, entirely hydrophilic wire, and it usually gets the job done. And the only thing to understand it is, because it is very, you are obviously going to wet it, it becomes very slippery, and sometimes the exchange of the accessories over it becomes more difficult. And the cannula, it makes your job easy. It can very easily glide through the tight the lumens, but at the same times the chances of causing a false passage or a mucosal subdissection or sometimes even a perforation are slightly higher with a thermo. So that's my usual practice. So.
Thank you, Bhavneet.
And Govindraj,
yeah.
this one I want to ask you whether I mean partly answered by a colleague, whether you normally go for a wire guided purely, or you any point you use a contrast to assist your cannulation. What is your way of doing things
Yes,
nowadays?
as far as the general practice is concerned, wire guided has come to stay now, and contrast, as I said, has become almost a history. But even with the wire guided technique, sometimes you are not able to cannulate, using a wire, which usually is a hydrophilic tip wire. Then sometimes you use a little bit of contrast to see the anatomy. You don't inject much, little bit of contrast with using a cannula at the tip, so that you can delineate the anatomy where the pancreatic duct, where the bile duct is there. Then try to selectively cannulate. That is where the only place where contrast is being used. Or sometimes you have hit a stricture, you have hit a stone, but you are not able to go beyond that. Then you use little bit of contrast to delineate what exactly is there, where you are not going to proceed beyond. So as far as cannulation, wire guided is the standard technique which is being followed.
Yeah.
Very good point. Using some amount of contrast so that delineating the anatomy. The ideal thing would be to take the catheter out, flush out that small amount of contrast that is there in the catheter, then use the guide wire. Suppose you use the catheter filled with contrast and use the guide wire, it is likely to cause more damage. So contrast, when you're using to delineate the anatomy, take the catheter out, flush it out with saline, then pass the guide wire.
Yes.
Thank you. Important practical points.
So one more thing, I would like to ask your opinion about doing a air cholangiogram in such cases.
Not much, because it is nowadays you don't do that much of an air cholangiogram. We don't practice in our thing. I think Professor GV can tell more about it.
Very good question, but actually it varies from center to center, basically depending on the type of fluoroscopic imaging that you have. It is not possible to see the air cholangiogram in the lower versions. Very high-end versions, which you would be able to see the thing. It definitely helps, but I don't think that should be the standard of practice in majority of the centers.
Thank you.
Thank you.
GV, you answered this question already. I think the Darmia or
Yeah,
balloon.
having a Dormia basket for stone, you should have a Sohendra mechanical crusher ready in their department. If the stone gets stuck, basket gets stuck, you should have a mechanical crusher. Unless and until you have that, please do not use the Dormia basket.
Okay, thank you. Thank you.
Thank you. And there's one more small trick where Bhavanith people try to explain when you try to drag the balloon. Then you have to have a technique so that it is in line with the bile duct. How you do, accomplish this when you are trying to sweep the bile duct with a balloon?
Yes, sir. So it's been shown here. It's the procedure is depicted here in this image, but I'll just quickly explain it for the beginners what it basically means. So the toe down technique basically means that when we are removing the balloon out of the lower part of the CBD and through the papilla, it has to come out in line with the axis of the CBD. The common mistake what beginners usually do is that they keep the scope static and they just keep on pulling the balloon, and that is where it can cause injury or slipping of the balloon or slipping of the stones can also happen. So the trick here is that when the balloon is in the lower part of the CBD, I keep looking at the fluoroscopy, and when I see that it is right at the lower end, then what I do is basically I first of all I have already logged my small wheel onto the right, and now what I'm going to do is that I'm going to do a down angulation. The big wheel goes towards the right, towards the down, and then I lock it there. And along with that, I just torque the scope clockwise and advance it a little bit. So this is what basically the toe down technique is. And what this does is that the balloon now automatically slips out, but it remains along the axis of the CBD. So this is what the technique is, and the idea is that this causes less injury to the papilla and less chances of the balloon slipping.
Excellent description. Thank you. Over to Govindaraj.
Yes. Um, this is nothing but a double guide wire technique, or people call it Goff technique. It was described by Goff in 1995. When you inadvertently, you always cannulating the pancreatic duct instead of the common bile duct, we use a double guide wire where you put a guide wire into the pancreatic duct and allow that guide wire to be stationary there. Then you use another sphincterotome, and you use that sphincterotome to pass into the along the guide wire into the pancreatic duct and lift the tip of the sphincterotome towards the 11 o'clock or the 12 o'clock position, and making sure that that is the way in which the trajectory of the common bile duct is. And then you give a very small cut there. In this very small cut, it should not be more than 3 to 5 millimeter cut you give. And when you do this cut, you in fact, you do a septotomy. You do a septotomy of the pancreatic duct. In this way, you open the lumen of the CBD. Then you do a selective cannulation of the CBD, and then you can cannulate this. This technique is otherwise called as the Goff technique also.
That's right. I think.
Thank you.
Now let us go into GV again.
Yes.
There are additional,
And
like the role of ERCP in
ERCP.
cystic stump leak and the
Yes.
leak from the duct of Luska. In these situations, post-lab coli, a surgeon, anxious surgeon, it can be easily, a patient can be recovered by this very important technique. Can you just enlighten us when you will do this procedure and how will you do this procedure, GB?
Very good question. Actually, this is the indication for post ERCP bile leak from the cystic duct or from the duct of Klushka. Basically, either because of a stone impacted at the lower end, or because of a spastic papilla, or because of a small tumor at the ampulla vata, the back pressure of this opens up the cystic duct or the duct of Klushka. So the basic principle of ERCP to treat these patients is to relieve the obstruction, the ampulla vata, so that the bile flows in the direction of the bile duct, and there is no back pressure that can leak into the cystic duct or the duct of Klushka. So this is the commonest indication, and the success rates and the patient recovery is almost 100% whenever we are doing an ERCP sphincterotomy in this patient. And whenever we have this, actually, if it's a very small leak, there is some data to show that simple sphincterotomy will be sufficient. But majority of the low-voice surgeons, when they are doing it, they're scared to do a full sphincterotomy. So I personally believe that whenever we're doing a sphincterotomy for ERCP for cystic duct and ductal flutional leak, I think you should cover it with a biliary stent. The stent is just acting like a splint, whether it's a 7 French stent or a 10 French stent, it is immaterial. But I think best would if you are suspecting a leak from the duct of Flushta, the stent has to go into the right hepatic duct. That is where it splints the duct of Flushta and also the cystic duct. I think the stent size does not matter. It is basically acts as a splint. So we do a good sphincterotomy and put in a stent. I think majority of the time it stops.
Thank you.
Thank you. Thank you, sir. Thank you.
And can you take this question,
yes,
Govindraj?
Yes. What is
acute
the
biliary pancreatitis?
Acute biliary. See, in acute biliary pancreatitis nowadays, the consensus is you do ERCP only for two reasons. Number one is when there is obstruction and there is acute cholangitis. Number two is there is no acute cholangitis, but there is evidence of obstruction of the stone is there on any imaging. Then it becomes a life-saving procedure. You do an ERCP, put in a stent in the CBD, remove the stone, whatever is there. In acute cholangitis, it reduces the toxicity, it reduces the septic shock in which the patient can be, and definitely it is life-saving. If there is no acute cholangitis, but definitely there is jaundice, but there is obstruction on an imaging, definitely there is a role for ERCP to put in a stent, remove the stone there, put in a stent. Otherwise, in any biliary pancreatitis, if there is these two conditions are not there, today's you don't have any role for an emergency ERCP. So emergency ERCP, usually they classify between within 12 hours and within 24 hours. The cholangitis within 12 hours and without cholangitis within 24 hours. This is what is usually the consensus that is being followed now. Thank you. Now, next question is to Dr. Navneet. Role of ERCP in chronic calculus pancreatitis. Which do you prefer, being a surgeon, surgery, or endotherapy?
So I actually select my patients depending upon what I'm looking at on a MRCP basically. So not all patients are suitable for, or not all patients of pancreatic calculus, chronic pancreatitis are suitable for endotherapy. But however, having said that, if I find that the patient has a diffuse pancreatic calcification, I would not probably go in for a pancreatic endotherapy. The patients usually don't benefit much. Ideal case would be probably having a stone which is present in the main pancreatic duct and it's causing obstructive symptoms, repeated pancreatitis and all. In such cases, what I will probably try to do is looking at the size of the stone. If it's a small stones, and small here basically means my cutoff is around 5 millimeters. Stones, pancreatic stones less than that, I'll just do a pancreatic sphincterotomy and try to do a balloon extraction of the stone. Any larger than 5 millimeter in size here, I basically do a sphincterotomy and send that patient for ESWL. Because mechanical lithotripsy is usually not a good option for pancreatic stones. Although nowadays we have the option of doing a direct pancreatoscopy and then doing either a EHL or a laser lithotripsy for the stones. So it is either ESWL or a direct pancreatoscopy followed by lithotripsy. And if the patient goes for ESWL, then if the stone has been thoroughly pulverized and now we are just looking at small grains, then I don't worry about it. I can just swipe a balloon and then, extract, or sometimes even that is not required because the small grain-like things can pass out because earlier pancreatic sphincterotomy has already been done.
Thank you.
That is in brief my approach for the pancreatic.
Thank you. And
I think very clear. Actually, only if that is dilated, I think and the stones are floating, and if there is a stricture beyond the neck of the thing, I think you should not venture. Multiple strictures in the pancreatic duct, no endotherapy. You have to go head bust, no endotherapy.
Very right, sir.
What is
the stricture is another thing we have to look at.
Yeah.
Definitely.
Another important thing, if this is inflammatory pancreatic mass, again, we should not go for the endotherapy. Well, unless we take out that inflammatory mass, patient will never get complete relief from the pain, which is the main factor.
And one more thing, sir, the role of EUS is also emerging. Chronic pancreatitis pain and all, we can do a EUS guided celiac plexus block also. So I forgot to mention. That's probably another way.
Thank you, thank you. Let me come back to GV again. And there are kind of cases where there will be patient coming back again and again with the recurrent pancreatitis, suspected pancreatic division. What is the current status and reliability of doing a minor duct papillotomy in those cases, GV?
Yeah, actually, this is a very good question. Actually, initially, patient with pancreas divisum with recurrent pancreatitis, people used to believe that you do a minor papillary sphincterotomy, patient do well. But there is no evidence to show that minor papillary sphincterotomy is benefiting these patients with for recurrent pancreatitis. So basically, only if the patient has any chronic pancreatitis, any stricture, these are the patients who, and they have pancreas divisum in association. In addition, I think these are the patients who would benefit from a minor papillary papillotomy. The basic reason why it does not respond is actually anatomy-wise, there is no sphincter for the minor papilla. So basically, it is not going to be of any help unless and until there is stenosis of the minor papilla opening. These are the only patients who benefit. But as of today, minor papilla sphincterotomy does not seem to help patient with recurrent pancreatitis with pancreas disease.
Thank you, thank you. Govindaraj.
Yes. Today, I think US has become a part and parcel of any therapeutic endoscopist, and they become more agile when you have an US and you're doing an ERCP. I would rate US into three different points where you need an US. Number one is you have a stone which has been diagnosed on one of the imaging, but you are very, very suspicious, and that is, you're not definite that there's a stone. And if you have an US, before doing an ERCP, put an US and confirm, because US is almost 96% sensitive when you are considering as a stone. So they call almost a gatekeeper for an ERCP. And number two is when you have a very difficult ERCP and you are not able to cannulate the CBD, then you do an ERCP kind of rendezvous maneuver and use US to cannulate into the CBD, and then you get a guide wire through the papilla into the duodenum, then catch hold of the duodenum, the guide wire in the duodenum, and then you do a regular technique of ERCP that is called a rendezvous technique, where you use an EUR directly to cannulate into the CBD. And the other technique is when you are not able to absolutely do any cannulation from the side, but you have got an obstructive system, there you can use an EUS instead of an ERCP to drain the system. You can do an hepatico jejunostomy or hepatico gastrostomy, or an CBD colidoco gastrostomy can be done by using an EUS. So these ways, I think US is nowadays useful in an ERCP. Thank you very much.
Thank you, thank you. I think now the spyglass is also picking up and is increasing indication. Can I ask Praveen, what are the classical situations where the spyglass is really useful? Is it something where you can put the money on, invest worth an investment? What do you think? Or with the balloon sphincteroplasty and other gadgets for biliary issues, whether it is like a robo, whether it is going to be an expensive investment? What is your view on this?
See, as far as our center is concerned, we whenever, instead of doing all these, balloon sphincteroplasty and then a balloon extraction, if one is not able to, repair, then, and if the gallbladder is polycystic already done, then only we use eyeglass to break the stone and to take it out. But if the gallbladder is intact and already we have to go for the cholecystectomy, then we prefer to do laparoscopic substitution with cholecystectomy in these cases, because in a medical college setup, it is very cost effective to use colonoscope in irrigation. And best in the for the is if you are not, stone is impacted, you are not able to go beyond the stone to deprive the stone. So that is the indication in which I glass in the stone. Otherwise, in malignant cases, again, to take the biopsy, because it's always challenging to prove whether it is restricted is benign stricture or malignant stricture in biliary strictures. Then to take biopsy, we definitely use spyglass endoscope. And in pancreatic cases also to confirm the diagnosis of the different intraductal lesions due to pancreatic spectroscopy of the pancreatic that is dilated. Then we use colonoscopy. So basically in our center, it is reserved only for the, if the gallbladder is removed and the stone is not recoverable, then we use colonoscope or in to confirm the whether benign versus malignant structure with the colonoscope. So I think as far as cost effectiveness is concerned, it will be viable only in high volume center. If the workload is not very high and we are beginner, I will not suggest you to go with the 5 challenges in the beginning of your career. That's all.
Thank you. Thank you for your rational approach for this problem. One of the common complications, Govindraj, please take this question.
Navneet, Bhavneet, post ERCP pancreatitis, what is your strategy for reduction in the risk, and how do you do when you have an ERCP, post ERCP pancreatitis?
Thank you, sir. That's a really important question, and I'm happy that you posed that question to me. So the first thing which I would like to say is that the moment you see the papilla, stop, wait. Do not rush to cannulate. I think the first thing which you need to do is to carefully observe and study and understand the anatomy of the papilla. Can we appreciate two separate orifices on your lucky days? But most of the time, in 90% of the cases, it's going to be a single orifice which enters into the ampulla, and then there is a septa which separates the CBD and the PUD. So we need to understand that. Spend some time there and try to visualize the 3D axis of where your 11 or 12 o'clock is, where your 1 and 2 o'clock is. As we say, dance in front of the papilla, do some mock maneuvers, just assess before you touch the papilla for the first time. And then when you're going to attempt that selective CBD or PD cannulation, you need to be very, very gentle. So I keep on telling the trainees here, treat the papilla as if you would treat your partner with a lot of respect and gentleness and patience. You cannot force your way into the papilla. It has to be a very smooth and a gentle maneuver. So besides this, there are a couple of other things which I do. The risk of developing a post ERCP pancreatitis is actually directly related to the number of times you are taking the attempt. So the cutoff is, as by definition, is 5 attempts or 5 minutes at selective CBD cannulation. And if you're not able to do that, or during these attempts, if you have one unintentional PD cannulation or the guide wire goes into the PD, this is basically now the time to change your strategy. Now go for the alternative techniques which we have been discussing earlier. You can try the pre-cut. You can try the double guide wire CBD cannulation, or you can just leave a stent in the pancreatic duct, which helps to straighten the CBD, and then you can get your guide wire into the desired duct. And if I'm using a CRE for sphincteroplasty, I make sure that I usually don't go beyond 15 millimeters of diameter, and my dilatation time is restricted to somewhere between 30 and 60 seconds. These are the few things which I try. And if at all, lot of pancreatic guide wire, the guide wire has gone repeatedly, then I make sure that I leave a PET there, which I'll probably be removing after 4 to 5 days. And obviously, there is obviously a role of prophylactic indomethacin, which has to be given, and good hydration. I think these are the two very important things to take care of the post-operative.
Thank you, Bhavneet. I think indomethacin is a very important.
Yeah.
And
can I ask this question to Govindraj?
Yes.
Sometimes you get some troublesome bleeding
Yes.
after the sphincterotomy. What do you do normally in those situations?
Yeah, this is a very important. I think you can divide this answer into either prevention and treatment. Prevention is how do you prevent this? Basically, you have to check for the coagulation-inducing tablets whichever the patient is taking. Nowadays, you don't stop aspirin, but definitely you have to stop warfarin or any kind of clopidogrel, whatever the patient is taking, at least 3 to 5 days before. And all the coagulopathy factors which are there, platelet count should be at least 50,000 above, and you should have the INR below 1.5. These are the things, standard protocols which you follow when you're doing an ERCP or any other surgery should be done, correcting the coagulopathy. And in the technique, certain preventions can be done, like instead of using a pre-cut, the pure cut, you always use an endo cut when you're doing an ERCP. That definitely reduces the bleeding there. And whenever there is, you are not sure that whether the patient has stopped the coagulating factors tablets, then you always do, instead of the sphincterotomy, you use a balloon. For balloon sphincteroplasty can be done, which reduces the bleeding. And whenever you are not sure of anything and you don't have a balloon sphincteroplasty, better to do a simple stenting to avoid cholangitis that prevents any kind of a complication there. And when there is a treatment for already there is an active bleeding is happening, what you do? The commonest thing everybody has is a balloon which you use for stone extraction. You can use that balloon, and a balloon tamponade can be done to reduce the bleeding. And this balloon tamponade can be kept at least for 2 to 5 minutes. That can be done, and if usually it stops the bleeding. And which we use in our technique. I think once Professor GV also, when he was there in our place, he was very appreciative. Is a safeguard solution or a para-acrylium solution. When there is minimal bleeding there, you spray that papilla with para-acrylium. It definitely stops the bleeding at least into 30 to 40% of the time. That is very useful. And certain people follow this injection technique of 1 in 10,000 adrenaline solution. You use epinephrine to inject around the bleeding area. This definitely reduces the bleeding. And certain people use thermal energy, the thermal probe can be done when you see an active small oozer is there. And certain times when the bleeding is heavy, you can use a hemoclip there to catch hold of the bleeding. And when everything fails, you can do a stenting, a self-expandable metallic stent can be placed to produce a tamponade effect to reduce the bleeding. And finally, always angiogram or your radiology help can be sought after to do an angiogram, and then you do an embolization can be done. And these are the techniques in which you can reduce the bleeding there. Thank you very much.
Thank you, Govindraj. I think finally there's one more nightmare question. I mean, problem.
Yes.
Probably perforation. And let us ask GV, especially beginning of the career. Sometimes we get into this trouble. How to prevent this happening, and if that happened, how to recognize and manage situations. GV. Hello, GV.
Oh, thank you so much. Now, this is the usual classification. Thank you for sharing this slide. The type 1 injury that occurs because of the tip of the scope that usually occurs at the junction of the D1 and the D2 on the lateral wall is the commonest injury that could require some sort of surgical intervention. And even this, actually, with some experienced endoscopies, we are able to tackle this. But still, the type 1 injury is the one which commonly requires surgical intervention. It is basically because of the tip of the scope that causes this injury, and usually the rent is quite huge. Now, the type 2, 3, 4 injuries that occur, the type 4 injuries which come occur in the hilar region. Now, these are the ones because the type 2 injuries are mostly retroperitoneal injuries. This can be managed very conservatively. Type 3 injuries also can be managed very conservatively because basically these are because of the guide wires or the catheters that we are negotiating through. So basically, it's a type 1 injury that requires a surgical intervention in majority of the patient. But type 2, type 3 injuries can be easily managed conservatively or endoscopically.
Thank you, GV. That's for very useful information. Now coming to the final two questions regarding the training of surgeons in ERCP, a sensitive chapter. How to train our surgeons, how long and how far they can get trained. Can we ask Professor Krishna Rao, who has been training for so many years?
Thank you, Ishwar. I've been keenly observing all the presentations. The training which you have in their ages is that they should have at least a minimum of 25 cases before they can do independently or elsewhere. But if you look at the American system, they require about 200 to 250 procedures per annum to be recognized and given privileges in a hospital. So that is the training that is required after you have gone through our basic first and second degree courses in endoscopy, the diagnostic and the preliminary therapeutic procedure. Only after that, he has to go on to the third phase of ERCP training. And ERCP is a difficult procedure with a lot of complications, particularly fatal thing is the pancreatitis. Hence, it is essential that the person is supervised during the first 20 to 25 cases of ERCP. And I don't know we have any Indian standard for the privileges in a hospital for doing ERCP for each and every candidate. And here, I would like to suggest that the person is starts off with another senior endoscopist to assist him during his first independent ERCPs, and follows all the precautions of preventing pancreatitis, perforation, bleeding, etc. So we have not yet put down the numbers of the required in our system, and I think that will be our next step to say what should be the length of training and assessment of training.
Thank you, sir. Can I just take the same question to Praveen regarding the, and because now there are a lot of simulation models have come, trying to take a little bit of burden from ourselves as a trainer, because we can't give the live cases unless they have the basic skills. So we have various models. What's your experience of this, and how we can use them in such a way to improve our surgical training in this skill set? Can you unmute yourself, Praveen? Please. Yeah, thank you.
So all these, simulations plus the animal models, they're of great help for the beginners, for the initial, till they get, used to all the hand movement, body movement, and torque movements. So they train themselves for all these finer nuances of the therapeutic endoscopy. But until unless you practice on the actual patients, you really don't become expert of this procedure. And I endorse all the views put forth by the Professor Rao. There has to be minimum 250 or 200 plus cases of hands-on training to become really experts in the RCP. And all these whatever animal models are there. So we need to progress step by step. Initially practice on the simulation and on endotrainer and simulation. And once you achieve a minimum competency level, then you can shift to the animal model. From animal model, you can before to where you can assess your competency level. Then you can shift to the actual on a hands-on training on the patient. So this structured training is very important, which is now quite doable in our Indian, senior, and a lot of these associations like IIGS or even ASI is working on it to give structured training program to surgeons to make them very competent therapeutic endoscopy. Not only that, we are working with NB body or even with the NMC to have proper therapeutic surgeon endoscopy course, 2 year post MS. So that as I keep mentioning that all these advanced procedures, whether it's a ERCP or ESD, EMR or OM, we just wherever there is a tissue cutting is concerned, we can we will have less learning curve. to get all these procedures in our armamentarium. We are working with the National Board of Examination and NMC to start 2 year uh, therapeutic endoscopy for surgeons course. So with this, definitely we can train more and more surgeons in a very structured way to make them very competent and skillful therapeutic endoscopists.
Thank you. Thank you. Govindaraj.
Yes. Yeah, I think training opportunities in India, I would like to ask Professor GV, then instead of Amol, I can also add on to that. Professor GV.
As in the training opportunities, especially actually, if you suppose if you see statistics wise also, even centers which are offering DNB, DM, gastroenterology or surgical gastroenterology courses, the number of cases done in majority of the centers is not adequate to train people in advanced procedures. I think this is, though it's a very blunt statement, but we know that as per the number of students, number of patients, number of procedures available, as of today, even in teaching centers which are training people for fellowship in gastroenterology and surgical gastroenterology, do not have adequate facilities to train these people. So for that reason, I think the simulation models are the ones which are getting very, very important. I think at least simulated training. And there are several centers across the country which are offering some hands-on courses, especially on the models, to get expertise, to get orientation, to get tips and tricks of the procedure. So as of today, except for select few centers, maybe not many centers are fully competent to give adequate number of cases, the cases mentioned to any of the candidate who is passing out. So most of the people, I think they are passing out without adequate training. So they have to be trained in centers where they are offering simulated training or in animal tissues, or they have to attend repeated master classes to learn the tips and tricks and master these things. Unfortunately, the training opportunities seem to be very, very limited centers across the country, because we cannot give hands-on training to any person who comes in, just walks into a place and he wants a hands-on training. Now the government of India, I think, is very, very clear about it. So it has to be in your center, it has to be under guidance, you have to do it. Initially, people used to go to other centers to get hands-on training, but the number of students in each center is so high that the centers are also not able to provide adequate amount of training to these people. So I think simulated training is very important as of today, to make sure that they get adequate expertise.
Thank you, sir. And I would add on to that is, I think two associations like the ASI and the IAGS have taken this very seriously. And I should thank Dr. Praveen Suryavanshi, because during his tenure as the presidentship, he started this Step 2 program where you train surgeons at the headquarters in ASI, where we have got a dedicated skills lab for endoscopy for surgeons, which has been donated by the Olympus company, and that has been put into very useful method. We have started with upper GI, colon we have started, and next would be the phase where we will be doing training surgeons in ERCP. Similar way as IAGS, Dr. Ishwaramurthy, myself, Dr. Satyapriya, led by Dr. Our BKR, sir, we have started this along with Bhavneet. We have started these courses, basic of the endoscopy is EFAGS course, and the advanced is called the FAGI course in ERCP, where we have a structured, as Professor GV said, it is simulated training, where we have a digital simulators, and we have got the animal simulators, and we have got now the artificial intelligence simulators from Mikoto. And this is basically, you give a very tip of the iceberg for all the surgeons to know what is exactly an ERCP. So they tend to learn this ERCP, then definitely they have to go to a mentor where they get trained in more number of cases, and then only they can do an ERCP on their own. And the learning curve is quite steep. Thank you.
Okay, thank you, Govind. I think I need to thank all the faculties having stayed close to 2 hours to give their excellent insight into various aspects of ERCP. Just a final one-liner from each of them would be good as a closing comments. Starting from Bhavanith, what do you think? One-liner for ERCP for surgeons. What do you want the take-home message for them?
Someone needs to be committed to learning ERCP. So there is no shortcut to learning ERCP, and the road to ERCP actually starts by learning upper GI endoscopy. So it's a long and a committed path, and one needs to be motivated enough to venture into this.
Dr. Praveen?
I think at association level, we need to get up more to take this challenge to train more and more surgeons for the therapeutic endoscopy. If we really want to make it available to the grassroots level across the country, I think we need to work more with same enthusiasm and commitment. That's all. Thank you.
Thank you. Govindaraj?
Yeah, I think leaders like Professor GB, Praveen, Professor BKR, Amit Mahadev, and Amol Bapai, they have all showed the path for how surgeons can be good endoscopists. And now it is the number of surgeons becoming an ERCPs is reduced. But now this association has taken up with the help of all these leaders. Definitely, I see a way for at least down the line, at least 10 years down the line, the number of surgeons taking up therapeutic endoscopy is definitely going to increase.
Thank you. Thank you.
I
And
take it
GB?
I don't take a totally different view on this. With the changing practices in the thing, actually, now the shift seems to be happening from ERCP to EUS. If you see any of the major meetings happening, actually, now they're talking about EUS guided interventions rather than ERCP guided interventions. And there are debates happening in the gastroenterology fields from ERCPs versus endosonologists. So the way it looks is actually with more and more publications coming in favor of EOS guided interventions, by the time we surgeons try to master ERCP, I think endosono is going to take a big lead. That is my gut feeling. So I think in addition, we are doing very good service to the surgeons by learning them, teaching them ERCP. But I personally feel if the surgeons of tomorrow want to practice some biliary endoscopic interventions, they should be very well versed with endoscopic ultrasound rather than ERCP. So I think there's a lot of shift. Now they're talking about primary CBD stone extraction via EUS government getting the bile. They feel that ERCP pancreatitis is the biggest culprit and they should avoid cannulating the papilla.
Thank you.
So
That's an eye-opening statement,
yeah,
GB.
actually, you understand there were debates in the recent meeting where the ERCPs are fighting against the endosonologists. So I think in future, maybe this is a very radical statement, but I think the way, because the guidelines are going to be dictated by the societies now, as in today, with more and more data coming in actually, for us actually, I'll tell you, in my own center right now, for obstructive jaundice, pancreatic head CA and periampullary carcinoma, we are running a trial between ERCP stenting and EUS guided stenting. And the data initially shows that actually there is no difference other than that the surgeon has some difficulty in dissecting the lesser omentum. So people feel that actually EOS guided drainage is better than transpapillary drainage now. So this data is going to get published very soon. So I personally think ERCP is okay, but I think some laparoscopic ultrasound and endoscopic ultrasound is a must for surgeons of tomorrow if they have to practice endoscopy.
Thank you. Thank you. And the final words of wisdom from our Professor BKS as
Ishwar, I was following each and every presentation. I have two comments to make. Today we are seeing a lot of abnormal gastric anatomy following bariatric surgery. I do not know whether centers like with GV Rao have any experience on abnormal anatomy and ERCP, because the numbers are going to increase in the future. Number two, the research thing, there were I have papers on biliary and ampullary sphincter spasm and manometry of the biliary and pancreatic duct. Number three is looking into the pancreatic duct and biliary tree without doing sphincterotomy is another one that papers are coming in there. The fourth one, I would like to add what G.V. Rao has said, that endosonography is now being used to drain the gallbladder into the duodenum or into the stomach when there is acute calculus cholecystitis. There is no need to do lap cholecystectomy by putting in the stent between the gallbladder and the stomach or duodenum. The biliary infected material is drained as well as the stones, and probably this may extend to normal bile duct or biliary calculi in the gallbladder. I do not know whether there is any trial going on with G.V. Rao. These are the things that I would like to comment as a completion of what I think of an excellent ERCP program. Thank you.
Thank you, Professor BKR, for your stimulating thoughts. I think there's a lot more unanswered areas in the ERCP. As GV said, everybody, it may not be the end of the road. We were used to thinking it is a Brahmastatra. Once you know ERCP, you know everything in therapeutic, but we are going in the US, lumen opposing strength, and a lot of other things. I think it is coming with the collaboration. We need to have more and more skills are developing. We need to embrace the technology. We need to get trained in all the techniques possible. As we normally say, as a surgeon with a good understanding of anatomy, hand-eye coordination, I think if you have a passion to persevere, perfect the art, and you focus yourself and see yourself as in this particular field. Don't try to do everything, including the endoscopy. But if you are going to kind of like what Amol or Amit or GB are trying to dedicate the time, I think there is a will, there is a way to go. And our motto as a trainer is to see more and more of our trainees get this important skill set. So those leaks of ducta brusca are drained, those small stones can be removed so that they can do a single session ERCP lap colis. There are situations where I feel surgeon ought to have this skill set. That's the reason we are all here. I'm very, very excited and thankful for all of you having stayed till 10 o'clock to contribute to all your insights. Finally, from Kanagavel, can you just give a formal vote of thanks? Thank you, everybody.
Sure. I think one more thing, actually, I personally believe that actually the cases that are being snatched away from the surgeons are predominantly cases which are being done with upper GI endoscopy and colonoscopy rather than from ERCP. I think surgeons training in advanced procedures using upper GI endoscope or a colonoscope, meaning to say third space endoscopy, other procedures, I think is more important because there hardly anything that they can snatch from biliary side, except for very radical procedures which are not done by routine general surgeons. I think, I mean, my personal opinion, I think you're putting in so much of efforts. I think they should be taught about some procedures which will help them retain their clinical practice. That is my
Point well taken, JV. Thank you. Thank you. Kanagavel?
Um, Thank you, all these senior professors, Professor Krishna Rao sir onwards. The entire gamut of super seniors are there for this meeting. So I'm sure it was a lot of information. I would say in one line, lot of information which have been deliberated in such a short time. So it is almost the entire arena of ERCP has been covered. I wish this recording remains forever in the IGS channel for the youngsters to get benefited. I wish this is made mandatory for those who are attending FAJI ERCP. Today is like a Bible discussion, it has happened. So in future, whoever does the FAJI ERCP should be made mandatory to watch this session of videos. This covers the entire 2.5 days ERCP program in 1 hour or so. So thank you all the seniors here, and especially thanks to the idea being mooted by Dr. Govindraj sir and Ishwar sir. And thank you, GV sir, Praveen sir, and Bhavnit sir for making this evening possible. And I also heartfully thank Dr. Sai, Mr. Sai and his team at Numerotech for making this possible. Sorry, friends. Many have been in the waiting time for some time. I apologize for that. Initially, we had some delays for about 5 minutes. On behalf of the organizing team, I sincerely apologize for making you wait in the waiting room. We will definitely try and improve on that side. I could see very eminent personalities in the attendees list. So, as a matter of fact, all good things have to come to an end. And with the permission of the president, we call the session a close. And IIGS has very, very important events lined up. The MINT program with Harvard is lined up in the second week of August. Then we have the colorectal collaboration with the ISU CRS with the CELSMA, that's the Society of Endoscopic Surgeons of Malaysia, which is going to happen in third week of July. And then we have a next very important program which is coming out in the Portsmouth Colorectal Society. Please visit IAGS.in website. IAGS is truly going international, and you have a lot of opportunities for attending the meeting. That's where you start networking. And IAGS helps you to get into the system of proper training. Either it can be short training, month-long training, or year-long training. And the icing of the cake happens in the last week of November, where IAGS collaborates with the ALS GBRI, where you get to spend some time in London, Trafford, and you also have an opportunity to spend some time in the institution of your choice on colorectal surgery and other subspecialties. So, with the amount of academic schedule on FAGS, the FALS programs, FAGI programs, EFAGS program, I'm sure it is far to get the benefits, take time and invest time on learning. Opportunities available for you to learn and for the career. So with that few words, I call the session a close with the permission of the president. Thank you very much. We look forward to meet you all in yet another academic event. Thank you very much. Good night, everyone.
Thank you.
Thank you. Bye.